Today's final talk takes us further into the realm of opioid-assisted therapy. Dr. Thilo Beck is a consultant psychiatrist and head physician at the Department of Psychiatry at the Arud Centre of Addiction Medicine in Zurich, where he has been working and researching for more than 25 years. Arud is a charitable organization running a multidisciplinary outpatient clinic for addiction medicine in the region of Zurich and is the largest institution in the field of addiction medicine in Switzerland. Today, Thilo will talk to us about heroin on prescription and explore the question, how restrictive must heroin agonist treatment be? And if we have time, there will be some questions afterwards, so please send them on Slido. Welcome to the stage, Dr. Thilo Beck.
Thank you. Thank you for the kind introduction, and thank you for the possibility to be here and to give you this talk about, well, how restrictive must heroin agonist treatment be? To be frank, I think it shouldn't be restrictive at all. So that would be the summary of my talk. But let's go through it first. To introduce our institution, we are a charity. We run, I think, one of the largest outpatient clinics for addiction medicine worldwide. It's a very sort of multidisciplinary approach because substance use disorders are complex and they come along with a lot of other problems. And I think we try to provide a treatment that caters for all different problems our clients bring with them under one roof, so that they don't have to go to different places to get their treatment. Here you see about how many people we treat. It's 2,000 people for alcohol, cocaine, cannabis, benzodiazepines, party drugs, and then mainstay for today, opiate agonist treatment. 900 people in what we call regular opiate agonist treatment with methadone, polamidone, buprenorphine, morphine, slow-release oral morphine. That's about 900 people, and then close to 600 people in heroin-assisted treatment. That's, I think, more than a third of the treatment population in Switzerland in HAD, so we are quite an important provider for that treatment. And you will see afterwards why we have so many people in heroin-assisted treatment. So that's an overview what we're going to do to this half hour. First of all, before we go to HAD, I want to introduce you into the Swiss experience, how we managed the opiate crisis we had in the 90s. That's quite a different experience to what we have heard right now here from Norway. And only then we'll get into HAD, especially into HAD, because I think we try to, what I call normalize heroin-assisted treatment. Our vision is to have heroin as any other medication to our disposition, because you will see most important thing is to get the treatment individualized and to tailor the treatment to the needs of our clients. And many of them prefer heroin. That's what we have learned. And they fare better in heroin treatment than treatment with other opioid agonists. That's something that illustrates what I just said. I think we should try to really tailor our treatments to the needs of our clients. And whenever they leave treatment, we should ask ourselves, what could we improve to keep them in treatment? And it's not about making the clients adhere to the treatment, but it's about improving the treatment to make them feel comfortable and make sure that they stay in treatment. And that's the Swiss experience. We had this big crisis in the early 90s, the largest open drug scene in the world, I think. About 2,000-3,000 people living and dying in Zurich at the open drug scene at Platzspitz, close to the main station. And on the right-hand side, you see what this Platzspitz park looks like today. So it's no more open scenes, no visible in Switzerland, I think, for heroin. And that's shown in the graph here. That's the incidence, how many people started using heroin. And you see the peak is early 90s, and from then on it went down. And now we are at a level, hardly anybody starts using heroin in Switzerland anymore. So we are close to the situation as it was in the early 60s. And on the graph, you see the measures that were taken. In the early 19s, we rolled out with low threshold methadone treatment. And 2 years later, HEAD was started. And this is sort of a very important message. Opiate agonist treatment saves lives. Everybody who is in opiate agonist treatment has a less risk to die. And so I think and this is a risk that can be reduced by 70%. So think about this. So I think most important is to get people into treatment and to keep them in treatment. All the other risks that are reduced with it, you can see here. It's infections and criminal behavior and better linkage to care. And that's a lesson not learned. I'm really sad to see this, what happened in the US. When people started to use OxyContin, it started with prescribed opioids, right? Pain medication. And then the doctors were crashed down on. They had to stop prescribing OxyContin. And what happened then? People were forced to go on the black market because there was no opioid agonist treatments available. So this is really sad and a tragedy, I think. So people are forced to get into heroin. And then came the third wave, that's mortality curve here, when the black market decided to replace heroin with fentanyl. And that was not the user's choice, that was the cartels that thought that was a better market model. So, and that's when the mortality really went through the sky. And this, I think this could all have been prevented when opiate agonist treatment would have been available early on. It's still in 15% in the US. This is just coverage. This is ridiculous. It's way too low. And another problem we'll get to later is the stimulant on the rise. This is the US curve. We have the same problem in Switzerland as well. I think in other countries worldwide as well. We get to that later on. That's the crack use we have in Switzerland right now. You see the last 2-3 years there was a considerable rise in Zurich, left-hand graph. Right-hand side, you see it's not all over the same situation. Some cities have a problem, others don't. That's another thing that concerns us. The right-hand graph, you see the green curve, that's the doctors, general practitioners offering opiate agonist treatment. And this curve goes down. So the generation of GPs that started to offer opiate agonist treatments in the 90s, they are now getting older, they're getting into pension. And the new doctors, they don't really take this over. And so what we see is the yellow curve, the institutions offering opiate agonist treatments, they take on these clients, these patients. And so it's more of a monopoly now that there is the opiate agonist treatments is more and more into centers. And I think this is a bad situation for the users because they have less choice where they can go to. The good thing on the left-hand side is the coverage. I think in Switzerland, we have a coverage that is close to 80% at a given day of people who have a problem with opiate use who are in treatment. So that's quite good. And 95 have ever been in treatment, 95% of users. That's a very interesting aspect of, I think, might be causal to the availability of opiate agonist treatment, that people, the ratio of people injecting is decreasing. Now we are in Switzerland, we have about 15% still injecting. The rest is either using nasally or orally. I think this is because the treatment is available and people are not forced to use the most efficient way to use the drug when they don't get there. Otherwise, it's injecting, right? And so it's not their choice, it's the most effective way when you don't get it easily. And so I think that's a very important result and the success of what we do in Switzerland, that people do inject less and less. And this is a very interesting graph. You see the thick lines, that's the situation in Switzerland or the canton of Zurich in general. And the dotted lines, that's the numbers we have in our institution. You see in our institution, heroin-assisted treatment, that's the red line, is increasing, ever increasing since the start of it. And it's now the most sought after treatment in our institution, with 37% in heroin treatment, followed by slow release oral morphine and methadone, buprenorphine and L-methadone. So that's the choice of the patients, the people in treatment. And that's what we recommend. I mean, the only way to decide what substance is good for what client is the decision of the client. They have to decide for themselves because what they tolerate best. There is no medical algorithm that you would sort of tell you what substance is good for what client. They have to decide for themselves. And they do decide that in our institution, clearly, they go for heroin. So the basic framework of good opiate agonist treatment is, as I told you, maximum coverage. Keep them in treatment as well. So you have to meet the needs of the clients and don't put any pressure on them. Try to sort of understand what they can come up with and what they can't. And treat comorbid disorders. Let the client decide, and choice of the best tolerated agonist. I think that's the most important thing. Sufficient dosing, reasonable management of on-top use. We get to that later on. And take homes. We'll get to that as well. I think in opiate agonist treatment, autonomy is key. People should live their lives and not spend their life at the treatment centers. And this is not helping people to integrate. It's keeping people from integrating when the treatment is so intense. So I think take-homes are a prerequisite for autonomous lifestyle. So that's for opiate agonist treatment in general. Now let's get to heroin, diacetylmorphine. That's a very special substance in a way because it's very close to morphine. It's only 2 C atoms added to a morphine molecule, 2 arms, the red sort of in red circles. And in this form, it's a prodrug. It has no effect. It only gets effective when one of the C atoms is taken away. Then we get the monoacetylmorphine. And this substance is effective and then is degraded into morphine. So why is this so different from morphine for people, for users? Because the diacetylmorphine is much more lipophilic and it gets resorbed in the brain much faster. So the effect you feel is much different from morphine. This is only for 2-3 minutes, but it makes the trick. It makes a difference for people. And we learned that over the years, that it makes a big difference. Some people are just not happy with morphine and are not happy with methadone. They get depressed with it. They need this instant rush to get stable. That's counterintuitive in a way, but that's what we have learned. And so we have to accept that heroin is, because it's acting so rapidly, it's the substance of first choice for many of our clients. When we started heroin-assisted treatment in Switzerland, people thought in '94, they will inject themselves to death, they will escalate, and because they get it for free, and so they will lose themselves. But this never happened. And there's a good reason for it, because as people in heroin treatment need this sort of changing effect, up and down, this rush, and then inject or use again and get the rush again, they have to stay in a certain dose range. If they go too high in dose, the receptors are saturated and they don't have this effect anymore. So there is no interest for people using heroin to escalate dose. That's what we see in treatment. They find their dose and they stay very stable with that dose. So that's a short history of heroin-assisted treatment in Switzerland. As I told you, first centers opening 94. Our center was the first to open. And that was highly supervised and mainly intravenous application. About 99% were intravenous. Then about 16 years later, heroin tablets were introduced. We started to use them earlier, but in 2010 they were approved. And they took over, I think, as I told you, about a large proportion of patients is taking the tablets now. Then 2011, we got away from the highly supervised treatment approach. 3 days take-homes were possible from then on. That's legally possible. And then 2020, there was a big change due to the pandemic. We were allowed to give 7 days. And since this worked so well, it was then... in the revision of the law, it's now written in the law that we can give 7 days from since April this year, officially, and that we also have the possibility to delegate heroin treatment to other institutions. That was not possible before. People only got heroin in our treatment centers, and from now on we can delegate other, like pharmacies or home care to give heroin as well, or prisons. This is heroin treatment is restricted in Switzerland. There's only 24 head centers licensed. Could be more, but anybody can do that. But you have to get the license. And there's about 1,700 people in treatment, and you see on the right-hand side, it's not all over available in Switzerland. There's only certain cantons that offer heroin treatment, which is not just, I think. People who are living in the cantons who don't have heroin treatment, they have either to move or they cannot get the treatment. And access to treatment is, as you see here, restricted in a way, but we can get exemptions for if they are substance rated. So we can also start to treat younger people or people who are on opioids for less than 2 years. That's possible if it's medically indicated. So here you see something that is very typical for Switzerland. It's a federal state, and practices are different all over. This is just a ratio. The dark gray, that's intravenous prescriptions or use in the centers, and the other columns are nasal or oral use or combined. And you see that there's a big difference between centers. Some centers, as ours on the right-hand side, it's only about 10% of people using intravenously. And other centers, there is 80%. So do they have a different treatment population? Are the people different going to these centers? I don't think so. I think it's the centers. There is some centers who hesitate to give oral heroin because they think it's going to be diverted or for financial reasons as well. It's more expensive, and they prefer to prescribe the cheaper substance because it's included in the price they get. So this is something that is not ideal, I think, and it's that there is these differences. I think many more people wouldn't inject if they wouldn't have to. So that's another difference. That was the situation before COVID hit Switzerland. How many % of people in treatment in the head centers in Switzerland do have take-homes? You see there is a range between 85%, that's our institution on the right-hand side, down to 5 or 2 or 3% of clients in treatment who get take-homes. So again, is it because the clients are so different in these different centers, or is it because the centers do have different approaches? I think it's the second. This is during COVID, when we were all allowed to give 7 days during the pandemic. And you see, even then, some centers didn't give any take-homes, even when COVID was acute, and because they thought it would not be justified for their clients. There was one survey of what the staff in centers think of rules and restrictions, and you see, even in this, also in the centers, they were not really happy with the way we could treat people sick at home, because it was difficult to get heroin back to their place. Take-home regulations, only 2 to 3 days, was perceived as not enough by half of that's the red columns, half of the centers. And again, provision in non-specialized institutions, that it was not possible to get heroin to prisons or other hospitals. So even the people working were not really happy with that. And now what people in HAD appreciate, that's an old survey we did, but it's still, I think, same opinions there. What people in HAD appreciate is flexible opening hours, individual dosing. In our institution, people can sort of regulate their dose in a certain range, safe range, to be treated as a human being, to have take-homes, to be free to live their lives. No mandatory psychotherapy or counseling. That's also a free decision whether you want to have therapy or not. And I think people have a right to get opiate agonist treatment even without counseling or psychotherapy if they don't want to. The central location and the discretion. So and the big experiment we did in COVID with the 7 days of take-home, people also thought that would be very difficult and that our patients wouldn't be able to cope with the 7 days take-homes. But we had fantastic experience, and you see what our clients think of it was like 9 of 10. And we got feedbacks like, that was the first time I had a regular life. I could do things I was not able to do before. Spend time with my friends, with my family, to work or to do hobbies or whatever, and a new experience. And on the left-hand side, you see the positive effect on top use of other substances. So people were more stable when they had the 7-day take-homes. They used less other substances. And that's what staff members think of the extended take-homes. I think most of them were also quite happy with it, even though there was about 18% not really accepting the fact that the clients would get 7 days. But they were very happy with the effect on the patients or clients themselves. And that's a very interesting survey we did towards the end of the pandemic. We asked our patients or clients how they use the tablets they get, take-homes. And 51% told us that they would snort them or use them nasally. And so that was what drove us to introduce this observational study to apply heroin nasally. So that's a heroin solution that is applied that way with the atomizer. And we started 2 years ago, and with big success so far. People are very happy with it, and it's either for people who have problems injecting, they have no veins anymore, or people who use tablets nasally. And they tell us that the effect is great, and they're really happy with it. So that's I think for the future, that's a very interesting route to follow. And so to wrap up, the key elements of what we call the diversified opioid agonist treatment is actually to give the clients the choice of the best tolerated substance, including heroin, in a sufficient dose and the preferred route of administration. And take-home should be a default. For other substances in Switzerland, we have opiate agonists, we have up to 30 days of take-homes. And my vision would be, why shouldn't that be possible for heroin-assisted treatment as well? Yeah, I think that's the main message here. And to what on top use of other substances, that's the last slide. I think first of all, you have to make sure that opiate agonist treatment is optimized, that the dose is right, and then that tends to reduce opiate use of other substances. Top use shouldn't be sanctioned. It's better to ask people why they use other substances than not sanction it, and to understand and to talk with them what one could do to improve the situation, why they use other substances. And I think urine tests don't really tell us much. They don't tell us how people use other substances. I think we have to talk to them to understand that. We have to address comorbid disorders that might be a driver for the use of other substances. And for the problem with cocaine use in opiate agonist treatment, I think we should consider agonist treatments with lisdexamfetamine, amphetamines, or that might be the future, to think about cocaine, like agonist treatment with cocaine. So that was my last slide, and I think we have questions now. Or
Great, thank you, Thilo. So we have time for a couple of questions. The first, if I understand correctly, the model for opioid-assisted treatment in Norway is very expensive, and so we're very curious, how do you afford all of this?
So in Switzerland, the treatment is financed by the health insurance, and it's a sort of a compulsory insurance that covers the costs. And there were so many studies how cost efficient opiate agonist treatment is. And if you compare what costs you can save when people don't get that sick and don't die and live better, so and are involved in less criminal behavior, so it's saving money all over. And so I'm not really worried about the costs of opiate agonist treatment at all.
Sounds like maybe we need to present these studies to our government here.
They are old.
They're old.
I mean, we did these studies in the 90s when we started to roll out the opiate agonist treatment on a large scale and heroin treatment. And they were reproduced in many other countries, and it's cost efficient.
What are the differences between morphine, methadone, and heroin in terms of how they affect the patient's health?
Well, all opiates are, if you compare it with other medications we use in medicine, rather well tolerated and harm very little. So you can live healthily and get old with opioids when you know how to use them. And the side effects compared with other medication we use for high blood pressure or whatever, they are much more severe. So I would say heroin and other opiates are rather healthy or safe substances. It's true, if you know how to use them and if you use them safely. And they are comparable. And also for opioid agonist treatment, whether you look at methadone or slow-release oral morphine or heroin, the effects are similar. I think but the trick is to get the right medication to the right person.
Do you know anything about how much of an impact stable availability and quality of street heroin has on overdose rates?
I think when people are in the right opioid agonist treatment, they feel comfortable with, they don't have that interest in using street heroin anymore. That's what we see. And that's why we introduced heroin treatment in the first place in Switzerland in 1994, because we learned that a quite big part of the treatment population on methadone wasn't happy with methadone, and they continued to use heroin because they didn't feel well with methadone. So when somebody is on the wrong substance, they will continue to use street heroin. If they are in the right treatment, they won't.
Thank you. Is Ola here? We had a question for Ola. Do we have any statistics on how many of the people who die from overdose in Norway are on opiate-assisted treatment when they died?
Yes, I don't have those numbers in my head, but it's a very small amount. So if you look at the people going into treatment and we're looking at the overdose rates of people who have been in treatment, they are very low. The majority of overdoses that we see in the Norwegian population come from people who have never been inside the opioid substitution therapy program.
Great, thank you. That's all we have time for today, so thank you very much, Thilo and Ola. Thank you.